Hello everyone, this is Dr. Mohit, your faculty for Dermatology. I hope previous chapters you revised them pretty well, the introduction and the lesions. Alright, so today we will be discussing about Papulosquamous disorder and telling you upfront that it's going to be little bit long and a lot of things to memorize and stuff as well, right? But it's going to be very interesting. I will take care of that, okay? I guess that is all for introduction. So let us just start with the chapter, alright? So right here, yes, so over here as you can see, right? So the word, we just go on to the word straight up, right? So papulosquamous lesions. Okay, so this word, right, papulosquamous lesion, this word characterizes a group of all the diseases. Okay, so what is this? This is just a clinical finding. Okay, so any disease, right, any disease which will have a scaly finding, yes, in the lesion and papules. All right, so those two things we are going to put this under papulosquamous lesions. Okay, all right, so that is all for the introduction of this chapter. Okay, and now what are we going to do? As you can see that I have prepared a very extensive list of all the topics that we will be discussing, some in this chapter, some in another chapter. All right, so we have psoriasis, lichen planus, Psoriasis 𝗵𝗵𝗵𝗵𝗺, seborrheic dermatitis, Rete's disease, neoplastic one, that is mycosis fungoides. We discussed the finding also about this, right? And tinea, eczema, Psoriasis rosea, and secondary syphilis. So all of these diseases, right, they have this one finding in them, that is they have these scaly lesions and we have papules. Okay, all right, so fine. In all of this, right, so in papulosquamous lesions, okay, so now what we are going to do is we will talk about psoriasis in very depth. Okay, all right, and we'll see how it goes. Okay, so let us just start with it. Okay, fine. So first of all, what is psoriasis, right? So I guess this word, this one disease, right, psoriasis, it has a lot of different findings as well, right, and it is correlated to a lot of diseases. Okay, and this itself has a lot of things. Okay, so what are we going to do after we're done with the introduction and the clinical presentation, right? So we will just make a complete flowchart of all the diseases that psoriasis has. Okay, all right, so we'll make a complete flowchart so that in our brain we have a proper pictographical memory that when I say acute gutted psoriasis, so with what type of presentation we're going to find. If I say nail psoriasis, okay, fine, it is there. If I say just palmoplantar psoriasis, okay, so you should know, like, you know, where what topic I'm talking about. Okay, so once we are done drawing that, yes, and after that I'll be asking you questions regarding the same. Okay, so after that you will have a complete orientation about this one topic, that is psoriasis. And psoriasis is that topic in dermatology. It is dermatology exclusive topic, right? I think this one thing we will all agree upon. Okay, all right, so just let us begin with this. Okay, so first of all, what is this condition? All right, so this is autoimmune condition. Yes, it is a chronic immune mediated inflammatory skin disease. Okay, all right, so a lot of inflammation happening everywhere. Okay, so in this image also we can see that the patient is suffering from all these erythematous lesions, right? Yes, on which side of the skin we can see the lesions? Tell me, extensor or flexor? I will answer to that. Okay, fine, so we're done with this one. So what are the etiological factors? So what are the etiological factors we can see in this, right? So it could have genetic predisposition, immune factors are there, and there are certain environmental factors. So all these factors we are going to talk about in detail. Okay, one by one we'll talk about it. Okay, so but main thing I want you to focus on are the all these things are triggering immune system. It is giving an unnecessary inflammatory signals. Because of that, the whole mayhem is happening. I just want you to get this one point in your mind. Then after this, all the histopathology, all the treatment, all the slides we're going to discuss, right, all the diagrams and everything will be clear if you just get this one point right, that you are going to see inflammatory changes. Okay, and because of these factors, yes, we have, because of the inflammation, right, happening in the body, all the interleukins and everybody, they are causing this. Okay, so that is all for the introduction part. Let us just go on to the genetic factors, right? So there are certain HLAs which predispose us to having psoriasis. So what are those? These are HLA CW6, B13 and B17. Okay, alright, so this is straight up, we have to memorize this. Okay, and the next one we have over here is HLA B27. Okay, a very popular one, right? HLA B27 we see in ankylosing spondylitis as well. Okay, so it is related with sacroiliitis. Yes, but the thing about this is that if this is positive, then there is an association with psoriatic arthritis. Okay, alright, psoriatic arthritis, this word is new for you, but as we go forward with it, yes, so you will be very familiar, like what is psoriatic arthritis, what is pustular psoriasis, what are the clinical findings, how to see, what to see, and all the questions, all the answered, everything will be answered. Okay, alright, so let us just begin. So this is one triangle that I want you guys to memorize. Okay, and whenever you see psoriasis, first that inflammatory point should come in your mind, that everything is happening because of that. Second is this, why? Because if we remember this, one triangle, a lot of clinical presentation, we can just easily maneuver our thoughts to that, okay, and we'll be like, okay, fine, I'm done. All right, one of it is angiogenesis. Okay, angiogenesis. Okay, fine, let's just write it down. What is angiogenesis, guys? This is just forming of new blood vessels. Okay, all right, that is angiogenesis. Okay, the next one is keratinocyte proliferation. Okay, alright, fine. So this is keratinocyte proliferation. Okay, so I hope you guys remember that in our introduction as well we discussed that we did not discuss completely about psoriasis, but one point I gave you that the epidermal turnover rate increases. Alright, the stratum basal, right? The stratum basal, like big smart guys love coffee. If you guys remember that mnemonic, big was for stratum basal, and in the stratum basal the keratinocytes, right, they are hyper proliferating. Okay, they are just being synthesized, right? They are dividing very fast. Okay, so because of this, what finding do we see in them? Tell me. If we have something as parakeratosis, right? What was parakeratosis? Parakeratosis was that we can nucleus in the cell of stratum corneum. Okay, all right. So I hope you remember this point from the introduction series. Okay, the first chapter of dermatology. Okay, the third point in our triangle. Yes, I want the reason I put so much stress on this word inflammation was because the third point of this triangle is the T cell differentiation. T cell dysfunction. Okay, so what is happening is because of this, the 𝗵𝗵𝗴𝗺 and 𝗵𝗵𝗴17, right, they are secreting interferon gamma and interleukin 17, right. So because of these two things, right, because of these two, what's happening is the basal stratum basal, the basal keratinocyte, they are getting stimulated. Okay, because of these two things, the basal keratinocyte, they are getting stimulated. Because of that, the whole mayhem is happening in psoriasis. Okay, so now I have connected the chapter 1, right, the introduction part. Like we just casually say that yeah, epidermal turnover rate is 4. Why? Because of this, right? Yes, so that is the reason why this topic is important, and it is very important, right? We just connect everything from the base, right, and we just incorporate that into the main topic that we're going to learn, so that we may never forget these things. Okay, I hope I made myself very clear regarding this. Okay, the next factors, first was genetic factors. Okay, so we have to remember that. Okay, the next one was the infections. Okay, so this infection that I'm going to write down is the most important one in psoriasis topic. Okay, whenever you read psoriasis, there should be one infection coming in your mind, which will be streptococcal infection. Okay, all right, let me just write that. Okay, alright, so why am I telling you that this is important is because if there is a history in a question we see, okay, fine, if we see that there was a history of streptococcal infection, after that the person has lesion and raindrop and they have lesions which look like raindrop, the answer is going to be gutted psoriasis. Okay, alright, so that is one finding, that gutted psoriasis. Okay, so revising this one point, that if we have a history about streptococcal infection and this gets us to a predisposition of having gutted psoriasis. What is gutted psoriasis? We will learn in a while. Okay, we going to learn in a while, but for now this becomes a predisposition, right? This is an environmental factor. Because of that we are having psoriasis. Okay, so the first point is done. Okay, and the next one is that there could be an HIV can also lead to a predisposition of having psoriasis. Okay, alright, not the gutted one, but psoriasis in general. Okay, psoriasis has a lot of different presentations. Okay, alright, so the next one is having drugs. Okay, drugs. So in these drugs, yes, so sudden withdrawal of steroids, yes, sudden withdrawal of steroids can lead to having severe pustular psoriasis. Okay, sudden withdrawal of steroids, those will be systemic steroids, not the topical ones. Okay, Alright, so this is one point. Okay, so the next point what I'm going to tell is very important. Okay, please listen very carefully. Why? Is because in psoriasis, yes, we never prefer giving steroids. Yes, okay, so steroids are contraindicated in psoriasis. Okay, but there is one condition where giving steroid is indicated, that is impetigo herpetiformis. Okay, we will learn about all these diseases individually. Okay, but I want you to be predisposed to this point, that by the end of this topic, this point is hammered in your head once and for all. Okay, I'll repeat my sentence once again, that systemic steroids are not given in psoriasis. Okay, they are contraindicated. Systemic steroids are contraindicated in psoriasis, but the only condition where we will give steroid is impetigo herpetiformis. Okay, alright, so we will continue this point again when we learn individually about these diseases. Okay, alright, fine. So there are certain drugs as well, that is beta blockers, NSAID, chloroquine and lithium, yes, which predisposes to having psoriasis. Okay, alright, and abuse, there could be alcohol history and smoking. Yes, so but these are very, I would say, diffuse thing, right? Yes, it's not specific that about these findings. And the winter, having living in cold countries, yes, and emotional stress. Okay, this could also have a predisposition to having psoriasis. Okay, alright, the immune factors, yes, this is the one we spoke about earlier as well. Yes, so I just want to highlight this topic once again for us, that immune factors, yes, what's happening are the pro-inflammatory cytokines. Yes, the cytokines, they are being stimulated, yes, by the immune system. Yes, the T cell which is being stimulated, that is in the Th1, yes, the interleukin 2, TNF alpha and interferon gamma, these things are being made, and 𝗲𝗵𝗵17 is making interleukin 17, and likewise interleukin 22 is made. All of this, what is doing, they are proliferating the basal keratinocyte. Okay, I hope you can link up all the story and everything, right? Diagrams are waiting for us, but now I just want you to have a very clear pictographical memory of whatever I am saying. If you have listened to the first chapter, well and good. If not, I am telling everything. Okay, from the base we are talking about everything. Okay, so that this topic is clear for us. There is no confusion in any point, not in the histopathology, not in the clinical finding, not in the clinical features, nowhere. Okay, we want this topic to be very clear to us. Okay, so these things are there. Okay, why? Because of the pro-inflammatory cytokines are increased, and these are the guys who are increasing it, right? So if we decrease it, this will be the treatment, right? Do you guys agree with me? If we decrease these, that will be the treatment, because that is the main etiology of it. Okay, let us go on to the next thing, that is the histopathology. Okay, yes, histopathology, why we will see is because when we take out a finding, yes, so in that, what all things, when we take out a biopsy, yes, and put it under the microscope, yes, and what all findings we will see. Okay, that is going to be our next topic here, the histopathology, and actually why understanding the whole thing. Okay, understanding the whys of it. First of all, right, this is one point, hyperproliferation of keratinocytes. This is one sentence we have memorized till now. Okay, we did it in introduction, we are doing it again. Okay, of the keratinocytes, because of the T cell response. Okay, because of this, what's happening is, we at the base we can see in the dermis, right, we can see dilated and tortuous capillaries. Okay, dilated and tortuous blood vessel we can see. Okay, and in this suprapapillary thinning. Okay, this sentence, suprapapillary thinning, is very important. Okay, so let me just, okay, this is good. Okay, fine. So suprapapillary thinning is important, right? Okay, fine. Histopathological slides are waiting for us. Okay, so just have a very good image, please have a very clear findings. Okay, we are going to correlate everything in a while. Okay, fine. So question to you guys. Yes, so we read about microabscess. Yes, so question to you, that if the neutrophils are accumulated in stratum corneum, what do we call it? Tell me. If the neutrophils are accumulated in spinosum, what do we call it? Okay, so these two things I made you remember in previous lecture, that when we were discussing microabscess, we made a whole table: eosinophils, neutrophils and lymphocytes. Yes, we made this whole chart. Yes, when we were discussing about microabscess. Okay, so we are gonna just take up the same thing again. So I hope you guys remember it, right? So first of all, if there is neutrophil accumulation in the stratum corneum, what do we call it? Yes, we call it Monro's microabscess. Okay, all right, Monro's microabscess. if there are neutrophil accumulation in the stratum spinosum, what do we call it? Okay, so I hope like you guys can in these notes, right? So you guys can what you guys can do, if you cannot remember, you can also search in this PDF. Okay, so I'll just so we have this, right? So you can search in this PDF as well, if you can see clearly that this was the thing I was talking about. Because we have written it like very all the words are in alphabetical manner, you can search in the PDF as well. Okay, it will be very helpful. This picture was very helpful in my preparation as well. Okay, so helpful for you as well. Okay, cool. So let us just discuss here itself that if it is in stratum corneum, it is Monro's microabscess. If it is stratum spinosum, it is spongiform pustules of Koebner. I made you remember like S for S. Okay, S for S. And now I have one more mnemonic in my head, that is MC, that is McDonald. Okay, and McDonald. Alright, fine. Let's come back to the current page that we're discussing now. So I hope that feature was good for you guys. You guys can use this feature, and probably whenever you have one word in your mind, if you are able to get on that page, or if you are using a book, just go back. Make sure we go back. Okay, this creates an interconnections in our brain, right? So by this, we can form the best memory, the best neurons, we can form by this, that okay fine, on that day I had this in mind, now I remember these three things because of that one thing. Okay, fine, let us continue. Monro's microabscess, and the next one was what? If it is in stratum spinosum, S for S, it was spongiform pustules of Koebner. Spongiform of Koebner. Pronouncing it wrong. Okay, these two findings we did. Okay, and the granular layer is absent, that is stratum granulosum, and also we call it as stratum germinativum is absent in the findings. And we have parakeratosis, where there are active lesions only there. Okay, all right, only at that spot have this finding. Okay, hyperkeratosis, because of the proliferation, right? There is because of the proliferation of stratum basale, right? We have this finding. Acanthosis, I hope you guys remember now. Acanthosis is a process, and acantholytic cell is another thing. Okay, we discussed the whole thing. Acanthosis, primary, secondary. What are the examples of primary and secondary? Okay, fine. Question to you guys. Okay, what is the reason for primary acantholysis? Okay, where is the problem? Tell me. The answer is problem is in desmosome. Okay, so I hope you guys can go back to that lecture or the notes or anything you guys made and have a reference that primary acantholytic cell is because of problem in the desmosomes. And how about the secondary one? The problem is not in the desmosomes, the problem is there in the keratinocyte itself. Okay, and tell me the examples. Okay, tell me the examples of secondary. I just want secondary now, because last time we revised the primary one. The example for secondary is HSV. Okay, HSV, we see multinucleated giant cells, those are clubbed together. Why they are clubbed together is because the desmosomes are okay, the problem is in the cell. Okay, so I hope I made this clear. We revised this at least 3 times in the class itself. We revised it at least 3 times, so because this is important for us, right? Okay, the next finding I want to discuss with you is the rete ridges. Okay, rete ridges and the papillary dermis. I hope you guys remember the rete ridges were the one which were coming from the top, right? Where the epidermis was going into the dermis, those were rete ridges, and where the dermis was going into the epidermis, those were papillary ridges. Okay, alright, so I hope this thing you remember very well. So the concept is from there, that about rete ridges. Okay, so in this, the rete ridges are so deep. Yes, they're so deep, we call them as camel foot appearance. Okay, that is called as camel foot appearance. All right, so that is one thing, camel foot appearance. Okay, so now let's come, if you have understood everything till now, well and good. If not, if you focus next 3 minutes, it is a summary of what we just did. Okay, but now this time we will revise everything with the help of an image. Come, the reason I have put this is a normal thing. We labeled everything together, right? If you remember in the first class, that this is the screenshot from our notes itself, that we labeled everything. Okay, so big strong guys love coffee. Okay, and these are the histopathological finding, and this is the diagram. Okay, first of all, let us just come to the very bottom part. Okay, all right, inflammatory cells, the ones who are causing all the mayhem are the inflammatory cells. What are they doing is because of this, what's happening is we have dilated tortuous blood vessel in the dermis. Okay, dilated blood vessels in the dermis. Okay, and because of this, yes, we are having, you can see these findings. right? What are these? These are the retty ridges, but these are so deep as compared to the regular one, right? In our diagram, okay, fine, we can try to make some, but okay, yes, the retty ridges are not that deep, right? But in this one we can see they are quite deep. Because of that, we have a finding called as camel toe appearance is seen. Okay, fine, camel toe appearance is seen. The next one we see over here, if you come on the top part, even though this diagram doesn't has all the details, but it is very good just to give you a rough idea about the histology, about the slide we're gonna see now. Okay, inflammatory cells we can see here, yes, and because of there is flaking of the skin, we can see the skin flaking. Okay, all right, so let us just come here, right, and see the histopath image. Okay, over here I can see, first of all, let us go mark the retty ridges. Okay, so let us just correlate this finding. Okay, whatever we just learned, now what are we gonna do? We're gonna find it all in this histopathological image. Okay, so first of all, if you just focus right on the bottom, right, what is this? These are the dilated capillaries. Okay, yes, if I just zoom it in, these are the capillaries, if you can see, and they are the lumens. Okay, fine, this is a capillary, dilated cap. Okay, and the Monroe's microabscess, right, we see, where do we see it in stratum corneum. Okay, and the other one, that was spongiform pustules of Koebner. Yes, these are seen in stratum spinosum. Okay, let us just try to find both of these two things. But first of all, I want to ask you one question, right? So what is one abnormal thing that you can just pick it up by yourself? Okay, just one abnormal thing. Okay, if I just tell you that the whole psoriasis topic, right, it revolves around this one thing, right? And in this histopathological image, we can clearly see that. Okay, 3, 2, 1. Answer is parakeratosis. If you answer it correct, well and good. If not, we will talk more about it. Okay, so now let us just take this opportunity, we label everything out. Okay, yes, and at least we'll point out everything. Okay, so first of all, right here you can see that the nucleus is visible in the stratum corneum. If you can really appreciate it, right? Yes, even though this image is not that clear, but we can clearly make out, right? Yes, all the nucleuses which we can elicit in the stratum corneum. Okay, fine, one thing is done. Parakeratosis finding is done. Okay, the next one is Monroe's microabscess. Okay, over here if you can see, what is it, that if the neutrophils are infiltrated in stratum corneum, let us try to find this. Stratum corneum is the one big smart guys love coffee. Coffee was the top one. Right here you see, guys. Okay, yes, if you see here, these are the Monroe's microabscess. Okay, the infiltration of these cells. That's it. The next important one is spongiform pustules of Koebner. Where do we find it? In stratum spinosum. Okay, stratum spinosum, if you remember, this was the most broadest layer, right? The most thickest layer. Yes, right here. Okay, it was the most thickest layer. Fine, and over here if you see these cells you see over here, these loosely adhered cells, yes, spongiform cells. Okay, these are the findings. Okay, and the neutrophilic infiltrations in the stratum spinosum. Okay, we see here. All right, about the next one, yes, we just in the starting we just saw these retty ridges. Yes, we saw them. These are what? These are just the epidermis getting deep invagination into the dermis. What do we call them as? We call it as camel toe appearance. Okay, all right. So that was all about this histological finding. Yes, I hope I made some justice to this one topic specifically, right? I wanted to add the normal image, what we labeled, and the histopathological image and the illustrative image all at one place, right? So I hope we made some sense out of it. Okay, coming to the next one, right? These are the types of psoriasis we will see. Okay, now what are we going to do? We will just make the whole chart, right? We will make a whole chart about psoriasis. Okay, and before that, even like if you have listened to the rapid revision discussion of psoriasis, right, even in that what we did a very to the point discussion about all these things, and especially this point was covered a lot in that. Okay, and we made a whole flowchart over there as well, so we will make it all again over here. All right, so I'll just show you what are we going to make. Yes, and I'll ask you questions regarding this as well. Okay, so let us just make this the whole thing by ourselves. Okay, and the guy in the center, the man of the moment, is psoriasis. Okay, fine. In psoriasis, what do we have? The main findings. Yes, so one of the main types of psoriasis it would be plaque psoriasis, okay, and pustular psoriasis, okay. So let us just write the pustular psoriasis here. Okay, alright. So, and this pustular psoriasis, it is divided into two types. Okay, one of the type is, it is divided into two types. One of the type is palmoplantar psoriasis, okay, and the other one is generalized type, okay, the palmoplantar type. Palmoplantar type, and the other one was generalized type. Okay, the generalized type. Alright, fine. But this the generalized type, right? This is a very severe form. Okay, this is a very severe form. We call it as the von ث1 reaction. Wunsch's reaction, or you can also say type. Okay, both of this we can see. But in this, there is a very classical finding. Yes, what is it? The answer is 𝗏𝗵𝗵𝗺 appearance. Okay, don't need to write it here. We have written in the next page as well, right? So we just try to make the whole classification, right? So in the pustular psoriasis is divided into two types: localized and generalized. Okay, and the localized we have the palmoplantar type. Okay, and in the next one we have the generalized type. The whole body is involved. It is 𝗏𝗵𝗵𝗺 appearance. Okay, in psoriasis. Okay, everybody who's getting a little bit comfortable, the next slide I'm going to ask you questions, so please lend me your ears. Okay, the next one we have here is plaque psoriasis. Yes, we have plaque psoriasis. So in this, there are also three more types of plaque psoriasis. Okay, these three, what I'm gonna write the first one, which is the most common one. Okay, so what word do we use for most common one? Please think on it until I write the answer. Vulgaris, right? That is answer is vulgaris. Okay, the first one I'll write is chronic plaque psoriasis. Okay, fine. How about the next one? But this is also called as psoriasis vulgaris. And a very classical finding I would just sensitize you now is that over here we find at the extensor surfaces, okay, of the elbows and knees. Extensor surfaces of the elbows and knees is a common thing in chronic plaque psoriasis, right? So in this, yes, so what things you have to keep attention, like put your mind on, right? Where do we have the lesions? The lesions are on the extensor surface. Okay, this is one thing I want you to make very clear of right now. Okay, and what do we also call it as? So we call it as psoriasis vulgaris. Okay, all right. How about the next one? So we did type 1. The next one I want to put your focus on is just the inverse finding, and that's what the name of it is: inverse psoriasis. In inverse psoriasis, just think what will be the manifestation, right, of this psoriasis is that whatever the classical finding we have in the vulgaris, it is just opposite to that. Okay, simple. So if this was extensor finding, so now we're going to find it in flexural areas, right, under the elbows, yes, in the armpits, yes, under the skin fold. We have this topic covered with great depth as well when it comes, right? The images are there. Okay, so please be sensitized with this one thing, that in inverse psoriasis, what are we finding, that the lesions are on the flexural aspect, and in the chronic psoriasis, where are the lesions? They are on the extensor surface. Okay, these two things please keep in mind, do not forget them. Okay, so whenever you read psoriasis, first thing should come in your mind is the common one. Which is the common one? This one, the first one we wrote is chronic plaque psoriasis, and in this one, what is the common finding? We find lesions on the extensor surfaces. Okay, coming to the next one. Okay, the next one, inverse psoriasis. We just got done with that. Okay, inverse psoriasis done. The next one we discussed it when we were discussing the environmental factors. Okay, and let me ask you a question. Okay, so in that I gave you that about one infection, right? One infection we talk about. What was that infection? 3, 2, 1. Streptococcal infection, right? It was a streptococcal infection, and in that I told you that if in a question or anywhere in a presentation the patient is coming to us and it has a history of streptococcal infection, and over there we have lesions on the skin which look like raindrop, it will be guttate psoriasis, acute guttate psoriasis, right? Okay, so this is that type of psoriasis which we were discussing in the introduction of the chapter. Okay, so I hope you can relate everything, right, one by one. I want you to make that complete circle, right, of all the things we learned. So nothing what we discuss is just like that, right? So we connect everything we learn, because if we do that, we have the best memory, right, and we will never forget it. The next one is inverse psoriasis, just got completed. The next one was acute guttate. Okay, so in this, raindrop lesions, raindrop lesions are visible. Okay, alright, so that is all about two types of psoriasis we just completed. First one was the pustular psoriasis and plaque psoriasis. Okay, alright, now let us just come and write the most severe form, okay, of psoriasis. This is an emergency in dermatology. Okay, usually there are not many emergencies in dermatology, but this one is. Okay, what is it? The answer is erythrodermic psoriasis. Alright, erythrodermic. Okay, alright, so this is the most severe form. How to manage these patients and everything, we will discuss everything in the treatment aspect. Okay, alright, so now we just be sensitized with all the classifications of it, which is most important part. Okay, so we'll just try to add a sticker here. Okay, fine. This is because this is most severe, we have to add this, right? It's a mandate thing. Yes, and in our whole series, so what are we going to do is I will be adding limitless tricks and limitless hot words. Yes, we will be continuously making these. Yes, so today one word is going to come. Please stay tuned for that. Alright, so fine. That was all about erythrodermic psoriasis. Okay, and even when we discuss about erythrodermic psoriasis, I'll tell you a point about this one word. Yes, so this thing will be very easy, and after you know that point, you will never forget this. Okay, the next one in the list is about the nail findings, right? It is nail psoriasis. Okay, alright, we have nail psoriasis, and the last one is psoriatic arthritis. Alright, fine. And even in psoriatic arthritis, we have to be very keen about these things, right? Okay, now it looks better. Okay, fine. So this was all the chart, right, I was mentioning you about in the start of the lecture, right, that we will make a chart, this is the chart I was talking to you about. Okay, so in psoriasis, so now what we will do quick revision, right? Please look into the screen very clearly. Yes, give me a minute or two, we'll revise the whole thing, and the next 5 minutes I will ask you questions. Psoriasis, first of all, psoriasis is divided into a lot of parts. Yes, so right on the top, yes, so what do we have it, right? We have the pustular psoriasis. Pustular psoriasis is divided into two parts, that is the palmoplantar type and the generalized type, that is localized type and the generalized type, right? And in the localized type, what do we have it in the hands and soles. Yes, and in the localized type, we have on the palmoplantar surface. Okay, the next one is the generalized type, the von Zomber's type, right? In this, what do we have? We have the lake of pus appearance is there. Okay, the pustular psoriasis is done. Coming on to the plaque psoriasis. In plaque psoriasis, we have three types. Yes, as you can see, three types of things are there. first of all, we just bang on to the point is we have the first one is chronic one, right? The chronic plaque psoriasis. In this, what findings do we have? We have the lesions on the extensor surface. Okay, and this is also called as, because this is a common type, we call it as Psoriasis Vulgaris. And the next one is the inverse psoriasis. Okay, inverse psoriasis, the findings are all inverse. Yes, the common one is on the extensor, this is on the flexular surface. The next one is acute gutted psoriasis, and in this we find the raindrop lesions. The history will be given of streptococcal infection. Okay, all the plaque psoriasis is done. Now coming on to the next part, right? The most severe form is the erythrodermic type of psoriasis. Okay, in this more than 90% of the body is involved. It's the most severe form, and it is a dermatological emergency. The next one is the nail psoriasis. Okay, the nail psoriasis could be individual, and usually it is associated with another type as well, right? So nail psoriasis, a lot of images are waiting for us as we go ahead. Okay, and the last one we have is psoriatic arthritis. Okay, fine. So that is all about the classification part. I hope you guys have some general idea, right? Whenever I say psoriasis, not just one like hyperproliferation of cell, 4-day turnover, those things, I think they are only for the first day lecture we discussed. Now if I tell you psoriasis, my students should know, you should be able to make this one whole chart. Yes, please. Okay, now questions to you, ladies and gentlemen. Psoriasis, yes. So what type of psoriasis is this one, which is divided into generalized and localized? So it is pustular psoriasis. Okay, the next one is this one. Yes, what was the type of psoriasis over here? Yes, this was plaque psoriasis, right? Okay, this was plaque psoriasis. Okay, and what was the most severe variety? It is erythrodermic type. Okay, and the photo of nail is given very obvious, right? But it is nail psoriasis. Okay, and the last one we have psoriatic arthritis. Okay, alright, so those things are there. Now let us go and see the images. Okay, images are here. What is this? Where do you find the lesions are on the trunk? No, the lesions are on the palm, right? If they are on the palm, we are gonna have what type of psoriasis we're gonna say that this is palmoplantar type. Yes. Okay, and this is a pustular type of psoriasis. Okay, we will see pus, the nature of pus, everything we will discuss in a while. Okay, even the nature of pus we should know. This is a very important question here. Is the pus sterile or not? This is the question here. Okay, so we will be discussing that. The next image is about this, right? This is generalized variety of the psoriasis. As you can see, the pus, the crust is already, we can see it is all dried up. The crust is dried up, right? So it is a lake of pus when these lesions were active, like in this. Yeah, you can see in this image the appearance we have is like this. You can see the pus is not dried up. Almost the whole body would be covered in this patient. This is just the posterior part of the leg. Okay, in the next one we have is acute gutted psoriasis. In this one you see very clear, right? Very clear demarcation. We can see the raindrop lesions. If you know the word raindrop, surely acute gutted psoriasis, you will never make it wrong. Yes, so this is the raindrop lesions we have. Yes, in the acute gutted psoriasis, history of which infection? 𝗧𝗲𝗹𝗵𝗺 infection. Okay, how about this one? So this image I used in the introduction, this chapter, right? So I hope now you can know that which psoriasis is this. So this is which one? Extensor or flexor? Flexor, extensor, right? This is the extensor surface. Right, this is the extensor surface of all the hand, right? So this is chronic plaque psoriasis. Okay, and if the lesions are on the flexural surfaces, so what is the answer? Inverse psoriasis, right? So this is happening in the armpits. This is inverse psoriasis. We have more images for this as well, right? As we go on to the lecture, we will learn in the next part. We'll learn each of these psoriasis in very great detail. Okay, fine. So the most severe form is erythrodermic psoriasis. We have right here, we can see the patient is immediate attention is needed, right? In this patient, if you can see the whole body is involved, it is an emergency. Yes, so the reason why we call this an emergency is because the patients could die because of cardiac failure. Okay, that is the answer here. Patients could die because of cardiac failure. Okay, how about this one? This is a nail psoriasis. In nail psoriasis, there are so many findings that I can see. Probably if you have read this topic, you can also see these. But when we discuss this topic, each of these findings, let me just zoom it in. This is a finding. This is a finding. This is a finding, right? And especially this is a finding. Yes. Okay. Everything, probably this is also a finding. Yes. So only if your eyes know, you will be able to see the exact thing. Yes, my father always says, right, your eyes will not see what your mind doesn't know. So I think a good teacher trains the eyes of the students. So I hope I'm doing it right. Yes, I hope I'm doing it right. So I'll be discussing all the points. Okay. All right. So the next one is the psoriatic arthritis. Okay. What's happening is because of the psoriasis, the great toe, the hallus, right, it is deviated. So which side is it deviated, right? So let us just discuss this one ortho topic right here as well. We also discussed this in the rapid revision part also, but yeah, let me put this point right here also, that this is the great toe, it should be like this, it is like this, right? So it is deviated. Which side is it deviated? That is the question. Medial side or lateral side? It is lateral side. Yes, so if it is lateral side, this is a hallus. Yes, this is hallus. Great toe, we call it as hallus. If it is deviated to the lateral side, what do we call it? What exact thing we can call it? I can write it on my case files. What can we exact call it as? Valgus or varus? Yes, what are we gonna call it? I hope you can come to a conclusion. I will give you 3 seconds. Okay, I hope you come to an answer, right? Okay, now I'll discuss the thing. Okay, so if the toe was medial, what would be called, and if it is lateral, what would be called? Okay, this is a trick. I used to be extremely confused in this topic somehow in my exams and stuff, right? So what is valgus, what is varum? Always confused, right? So whenever I used to read it, I used to be like, okay, fine, I know this now. If I have a question, definitely the question is not going to be wrong, and these questions definitely show up in our exams, right? All the Q banks and everything, they are filled up with this. If you don't have the concept right, you will get it wrong. What is the concept? Let us discuss. The concept is that we have to see the deviation after the joint. Yes, for example, in knees, if you want to see knock knees, yes, so what do we see? Where is the deviation? The deviation is lateral in the first image. Yes, the deviation is lateral. If it is lateral, what do we call it? If the deviation is like this, right, it is on the medial aspect after the joint. Please, all these things, the words are not important. What the important word is after the joint. This is the joint, this is the joint, this is the joint. Please be very careful about this. Okay, all right. So if it is lateral deviation, it is valgus. Okay, how I remember this is, you can also remember it like this. Okay, too big. Okay, lateral. Okay, you will never make it wrong. I promise you, you will never make it wrong if you use this one trick. Okay, your eyes will be very trained that if it is lateral, just see in the image, if it is going on the lateral side, valgus. Whatever it is valgus, right? We can see in the cubital fossa, right? In the gun stock deformity, right? We have this, that the arm, the radius ulna, they move towards the lateral side. So what is it? Cubital valgus or cubital varus? Right, to lateral, right? So it is cubital valgus. Yes, very simple. If you know this one topic, it is very simple. So I hope this part was very clear to you guys. Yes, that which is valgus and which is varum. All right, fine. So now let us go on with the individual parts in psoriasis. Okay, plaque psoriasis. Okay, so I hope you remember the chart, and it's on the very left bottom part. Yeah, so this is going to have 3 types. Yes, so which are the 3 types? Please please repeat after me. The first one is the chronic type, second is acute guttate type, third one is the inverse one. Okay, so I hope at least the names are clear for us by now. The amount of time we invested just to learn the classification, I hope it will justify the outcome. Okay, fine. So first thing, you know that psoriasis vulgaris is also known as chronic plaque psoriasis. Okay, fine. And typically it presents with sharp demarcated scaly lesions. Okay, scaly lesions on what? This also a point we discussed. Is it the answer is going to be extensor or flexor? Okay, so answer is going to be extensor surfaces. Okay, all right. So where do you see it? We see it in elbows and knees. Okay, this point also we discuss, and even this. Okay, so elbows and knees will be the location. Yes, we will see this most. Okay, actually one of my known person had this. Okay, and at that time I didn't read psoriasis very clearly. Okay, and what happened was I saw his lesions and everything. I saw like, okay, fine, there are like a lot of unusual patterns. Okay, just to put it that way. But then after I saw, like, especially same as this image. Yes, same as this image, he had his on the extensor surface, he had a very big flaky thing. I was like, oh, what is this and everything. He told me like, this is psoriasis. I thought, okay, no, why this is psoriasis? I don't think this is psoriasis, but no, I am diagnosed case of psoriasis. Okay, and he's very young guy, yes, and it was that, and he was taking the whole treatment, yes, so and quite a lot of involvement of his body in a very young age, yes, so even though he was taking such a good care about everything, but yes, and his etiology, he said like why did he had it, he said it was because of stress, something in his life happened, yes, and it was he was so much stressed about it that his body shoot up the whole thing. That is what he claims to be the reason. Okay, could be another as well, but he was a case of chronic psoriasis, same as this patient. So I hope this whole story, by the story at least you can remember that fine, psoriasis common, extensor, fine, we made a good concept here. Okay, fine. So if you guys remember triangle, okay, it is the same with easy words. Okay, I change after words a little bit. Okay, so new blood vessels, angiogenesis, thickening, yes, thickening was what? Yes, increase in the proliferation of keratinocytes, right? Okay, that is one for that. And scaly lesions, yes, scaly lesions are developed. Why? Because the because the epidermal turnover rate is increased. Yes, that is the reason we have scales. Scales are like pretty common, but one type of psoriasis does not have scale. Yes, keep this in mind. Okay, one type of psoriasis does not have scale. We will learn about it. Let us continue. It is inverse psoriasis. Okay, inverse psoriasis. This point we know that the lesion will be on a flexure part, and okay, and no scales will be there. Yeah, non-scaly. Non-scaly. Do you think there are scales in it? I cannot really appreciate that many scales as compared to our previous photo that we took. Yes, the previous image that we took, it had a lot of scales in it. Yes, so as compared to this one, you see, yes, you see the flakes. So clear demarcation in both of these two images. Scales present, scales absent, okay, inverse psoriasis. Okay, so I hope this point you will never forget. Okay, the next one we see in the list is acute guttate psoriasis. Okay, so you remember the image we had in the previous one. Okay, what is the word I told you to remember? Yes, what is the word? The word is raindrop lesions. Okay, all right, raindrop lesions, and this is also called as raindrop psoriasis. Raindrop psoriasis. Okay, typically after history of what? Tell me, come on guys. I hope you can answer this. Yes, if not, then no worries. We can answer it after me writing it down. It is streptococcal infection, right? There is always time to learn and improvise, right? Okay, lesions are less scaly. Even so in acute guttate psoriasis, what did we just learn? That the lesions are less scaly. Okay, non-scaly lesions are seen in which one? In inverse psoriasis. Okay, alright, and in the classical variety, the vulgaris type, which lesion? Scaly and non-scaly? Definitely scaly. Okay, so what do you think will be the treatment? It is pretty straightforward. The treatment is not that complicated in dermatology. Yes, definitely not complicated. Little bit probably in this as we go ahead, but everything we can resolve by just a normal thinking. If there is streptococcal infection, first of all, we would handle the infection, right? We will handle the insult which is happening to the body. Yes, so we will give antibiotics for that. Yes, and also we would give the phototherapy. Yes, phototherapy is coming, waiting for us. Yes, at the very end of the discussion, phototherapy. We would go in great details about this as well. Okay, but if everything is not done, it is a self-resolving condition, so nothing to worry about. Yes, so if you treat this patient or not, he will get treated by itself. So if a doctor comes in and he treats the patient, it is a good popularity. Yeah, for a doctor, right? Yeah. Okay, fine. Coming on to the next one, ladies and gentlemen, what is this? This is a pustular psoriasis, right? So if you remember the diagram, if you remember the chart, you know that these have two types, pustular psoriasis. Yes, which one? One is the localized type, one is the generalized type. Localized type was palmoplantar type, and the generalized type was von Zumbusch reaction, lake of pus. I asked you to remember this much, right? So I hope you remember this, and I hope you are at least familiar with those words by now. Okay, very important. Okay, fine. The next one is, why is it triggered? Why? The answer is, why is it triggered? It is because of stoppage of systemic steroids. Okay, sudden stoppage of systemic steroids can cause of having pustular psoriasis. Okay, and do you remember that point I told you? Yes, I hope you do. Yes, what was that point? If you can recall, something with the impetigo name. Yes, is waiting for us. Alright, fine. These are two things we just mentioned, localized type and the generalized type, palmoplantar psoriasis or pustulosis or von Zumbusch type right here. Okay, so I told you initially, right? So one limitless hot word is waiting for us down the lecture. This is the one. Limitless hot word for today is gonna be lake of pus. Yes, wherever you see lake of pus, just straight away go up to the Von-Zumbu's reaction, very specific word for this. Okay, so as we do the whole derma, we will just keep on making list and list and list of all these things we remember, right? Images, we will do images at the very end. We'll discuss all the images. Yes, it will be like a retro revision for us, right? And we will make a list of all the signs and all these limitless hot words as well. Okay, so we can compress all the information. Okay, all about compression. Okay, this was the thing, right? I was just asking you about that Von-Zumbu's type. Yes, in pregnancy is impetigo-herpetiformis. Okay, all right, impetigo-herpetiformis, it is in pregnancy. Okay, when it comes, when it goes is also important. We will discuss that, but first thing is, it is a misnomer. I hope you please mind this. Okay, please mind this, that it is a misnomer. Okay, there is nothing herpes in it, no herpetic infection involved in it. Okay, no HSV, no HPV, no nothing. It suddenly happens. Okay, so tell me, what is the treatment for it? We did discuss the treatment as well. Tell me the treatment. Treatment is gonna be what? We will give steroid. Even though steroid is complicated, this is the only condition in psoriasis that we will give steroid. Okay, so let us see the images. A pregnant lady, you see it has such geographical lesions. Yes, and okay, even in this image you can see right here. Alright, even this in this image as well, as you can see that it is quite an extensive involvement, especially the trunk is involved, this is involved, the groin is involved, the extensor surfaces of the knees are involved. Okay, fine. So to answer the question, when does it occur? Yes, so when does it occur? It occurs in the last trimester, most commonly. Okay, most commonly it occurs in last trimester. Okay. When does it resolve? It resolves in the last trimester, or when do you think it resolves? It resolves after the delivery. Okay, all right, so this is the point we just spoke so much about, right? This point, what was the point? That only condition in psoriasis which we will give systemic steroids, it is impetigo-herpetiformis, the one which we are discussing. Okay, so tell me one question. Yes, one question to you. If steroids are contraindicated, then what are we going to give? For any given reason, steroids are contraindicated. How we will manage this patient? Yes, so in that condition, we would use cyclosporins. Okay, please, exceptions are the areas where the examiners are most interested in. Yes, because if somebody has not read anything to this depth, probably he would just flick off in the first 10 seconds. Yes, so please mind this. Okay, cyclosporins, we just discussed about it. Okay, so coming on to the next one, erythrodermic psoriasis. Yes, so fine, we know few things about it already. It is the most severe form. Yes, so erythrodermic, over there I told you, I will tell you one point about this and you will never forget it. Okay, what is that point will be discussed. So the lesions, how do they start? How do they start is, yes, so what happens is, initially the lesions are very small. Yes, but what they do is they keep on merging with each other. Yes, so as the lesions, yes, so they keep on merging with each other. Yes, so they keep on getting fused, and eventually what happens is they reach to a condition where more than 90% of the body is involved. So any condition where there is more than 90% of involvement of any disease, the answer would be erythroderma. Okay, it is a general term. I'm not telling dermic, I'm telling derma. Erythroderma, more than 90% involvement of any disease. Okay, this is a general point. Erythroderma. Alright, fine. Let us just write this one point here. Even when I learned about it, I was pretty excited. More than 90% of body surface area. Okay, so I guess because these are the very small points, right? If we know, it gives us the confidence that, okay, fine, I know what it is. Even though, like, maybe down the line you forget these things, you will maybe you hear the word erythroderma. Oh, this is very serious. This is very serious. More than 90% involved. Even though you don't know anything, right? You know when this happened, what this happened, but you will remember these points. We call it erythroderma. Okay, fine. Very severe condition you can see here, right? Okay, what is the treatment? Treatment is gonna be, we would want to decrease the immunity of the patient, right? So one magical drug we have to get control of the immunity, right, is the Methotrexate. Methotrexate, very important drug, the magical drug, like for to manage this patient, methotrexate, right? And the response is beautiful response to this one drug, methotrexate. The next one is cyclosporine. Okay, when do we use it? Cyclosporine, this name you will hear whenever there is a flare up. Okay, I have also written here for flare up. Okay, whenever there is flare up condition in anything, in psoriasis, not just in erythrodermic, in any of the psoriasis, if there is flare up, we would give cyclosporine. Okay, we used cyclosporine before as well. Tell me what is the answer. When did we use cyclosporine? Yes, answer is 𝗵𝗵𝗴𝗺𝗺. Was it the drug of choice? No, it was not. What was the drug of choice there? Steroids. Yes, systemic steroids you would give. But then why are we talking about cyclosporins in 𝗵𝗵𝗴𝗺𝗺 is because that if there is contraindication of steroids, we would give cyclosporin. I hope these 2-3 points are very clear to you. Please take these important points with me. And we also give acitretin. Yes, vitamin A derivative, it is also coming. We'll discuss about this as well. Okay, vitamin A derivative, acitretin. More images for us. Yes, as you can see, it is such a very heavy involvement, right? You can see in the whole eye, like it's complete involvement, very severe condition. The next one is psoriatic arthritis. Okay, psoriatic arthritis. So I hope you have that whole chart made in your mind. We are covered with the pustular part, we are covered with the plaque part, now we covered with the erythrodermic part. Now we are going to the psoriatic arthritis and followed by nail psoriasis. Okay, alright, fine. So psoriatic arthritis, ladies and gentlemen, first point right up, I would like to take up the third point here, that is seronegative spondyloarthropathy. What is this? It's such a long word, seronegative spondyloarthropathy. What does it mean? Is that the rheumatoid factor and anti-CCP are absent. They are not positive in this patient. So this means that they don't have arthritis. Okay, got clear? This is very important point. I just wanted to start with this very important thing. Even though we are using the word arthritis, it does not mean that the rheumatoid factor and anti-CCP are positive. They are negative. Okay, please mind this. So both of these are negative. Okay, alright, fine. We do have association with HLA, that is 𝗏𝗵27. We read this in the genetic predisposition as well, right? Okay. Also has ankylosing spondylitis. Yes. Yeah, we did that. And having nail psoriasis increases the risk of psoriatic arthritis. Fine. This is one of the finding. Okay. When we discuss about nail psoriasis earlier, when we were writing the whole classification, I told you this point that having nail psoriasis, it predisposes to having psoriatic arthritis. So it is not just a very secluded type of finding. Nail psoriasis I am talking about is not a very secluded type of finding. It can be found in other psoriasis as well. Okay, criteria. This is a question, ladies and gentlemen. Which criteria do we use? Casper. Yes, Casper criteria we use in this. Okay, we use Casper criteria. No need to memorize the whole criteria. We remember the name, is more than sufficient. Okay. Now let us just talk about this image right here. Okay, fine. So this image could be very confusing. First thing, it could be very confusing, right? Because similar sort of findings we do see in arthritis as well. So how can we differentiate? How can we differentiate this image? Yes, and the patients of rheumatoid arthritis. Very hot topic, very important key concepts will be discussed here. Okay, alright. So if you give me next 5 minutes, I'll make sure you go home with confidence that okay, fine, I know how to differentiate between two things. Alright, so let us just start with it. First of all, let's follow up these points. Asymmetric oligoarthritis. Okay, only DIP is involved. Distal interphalangeal joint is involved. Okay, we are talking about psoriatic arthritis. Okay, please mind this point that only DIP is involved. Okay, and spondylitis and sacroiliitis, yes, and sausage digits are seen. Okay, these digits, if you see, they are quite swollen. Yes, the DIP, PIP both are swollen, right? So it's giving like a sausage appearance. Okay, Alright, sausage digits. Okay, very peculiar word about the psoriatic arthritis. Okay, fine. Okay, how about this one? Let me read this out for us that it resembles rheumatoid arthritis except erosions of terminal phalanges, tufts, tapering of phalanges or metacarpals with cupping of proximal end of phalanges. Very confusing, right? Okay, let us just see what it means. Okay, let's come here. On the left side, these two diagrams we see are of normal rheumatoid arthritis. Let us just see these two things. Very good depiction, to understand this concept. Yeah, in over here you see, the distal DIP are not involved. If you see the DIP is not involved, only the are involved. Yeah, proximal ones are involved, distal ones are not involved. If you guys are getting confused which is distal, which is proximal. Now what does distal and proximal mean? Yes, so if you are getting confused, and what is distal, what is proximal, so if you go by this trick, you will never forget it. So distal mean दूर का. Yes, distal means दूर का, very far. Distal means distant. Okay, and proximal means near. Okay, alright. So now we know that these are not involved in rheumatoid arthritis, but PIP are involved. Okay, even if you see in this one, even if you see like in the feet, you see this is involved, not involved, not involved, not involved, not involved. Okay, over here you see in the psoriatic arthritis, the first of all the whole phalanx is involved, right? Complete phalanges are involved in this. Okay, we have the PIP, we have the DIP, PIP, both are involved. Okay, both of these are involved. If you see here as well, both are involved. So now you know why do we see sausage fingers. Yes, because like in our hand, if the DIP and PIP both are involved, there is inflammation in both these joints, right? So it's going to be swollen, right? It's going to be swollen. So that is the reason. Yes, so we see this. Okay, and if only the PIP is involved, it is RA. Yes, so we have Botnier's deformity, we have swan neck deformity, all those things are also there. Alright, but for now we are just focusing on psoriatic arthritis and its key findings. Okay, so now I hope this image is very clear to you. Okay, alright, so I hope you can get a very clear demarcation of this whole thing, that rheumatoid arthritis, what is involved, what is not involved. Okay, now let's go on to the next thing. Okay, now we have seen the clinical finding. Now we'll see the radiological images. Okay, what findings do we actually have in this? Okay, so alright, X-ray findings. Yes, so we will have, because of the erosion, right, we are going to have something known as pencil in cup deformity. Okay, alright, because of the erosion it is pencil, and because of the bone, yes, we have a cup. Alright, so because of this point, pause, cut from the point where I am making this. Alright, and continue. So now to continue that topic, yes, so what are we going to have? Yes, so this is going to be pencil and we will have a cup. Why we will have this finding is because of the erosion of the terminal phalangeal tufts, erosion, yes, and tapering of phalanx or metacarpals, yes, and there is cupping towards the proximal end. So that is the reason we have that. Okay, pencil is formed because of erosion. Alright, so that is one thing I want you to get. The next thing is what about the treatment part? Yes, treatment we would go along with, the first line would be NSAIDs, yes, and the DOC would be methotrexate. We discussed this one. Methotrexate would be the drug of choice for the psoriatic arthritis. Alright, and sulfasalazine is also given. Biological agents are the second line. We are going to discuss about this as well, right? Which biological agent we should give, and what are the classifications. We would discuss this one topic individually as well. Alright, so let us go on to the next one, that is the nail psoriasis. Okay, fine. So earlier as well, right, we discussed about the nail psoriasis and that image was there. Okay, so now what are we going to do? We will just segregate and we'll learn together. We'll learn everything, that what are the key findings. Yes, so too many hot words here which are very specific to this one topic. Alright, so let us just get all these findings I have accumulated all of this in one page, and it would be very nice. Alright, fine. So let us just start with the first one, that is oil drop cataract. No, oil drop nail. Okay, we are not talking about oil drop cataract, galactosemia, no, oil drop nail finding. Okay, also called as salmon patch. You can see very good image, excellent image. Where do you see oil drop? On the nail or beneath the nail bed? Beneath the nail bed, right? That is the answer. Okay, you see in this, can you tell me where is it? Is it this? Definitely this, right? Okay. Okay, fine. This is the nail drop finding we have. Yes. So how would we describe it? Is translucent yellow red discoloration beneath the nail plate. Okay, beneath the nail plate we see this. And okay, fine. The next one is subungual hyperkeratosis. Even if you just break these two words, you will understand what the whole thing is. So subungual below the nail hyperkeratosis. We have been abusing this word since we started the derma. Okay, hyperkeratosis. You can see over here, right? Because of the extreme proliferation, right, in the base of the nail, you can see that it's almost being uprooted. Yes, the nail is almost pushed. Yes, you can see. Because of this, we have another finding called as onycholysis. Yes, the separation part is called as onycholysis. Okay, separation of the nail plate from the underlying nail bed. Alright, so separation is onycholysis. Alright, the next one is nail pitting. Nail pitting, everywhere you see, you will have this one word, right? Nail pitting, very characteristic of nail psoriasis. Okay, fine, nail pitting. And first of all, why do we have it? We also called it as thimble pits or nail pits. Alright, this is there. And why do we have it is due to the invagination of proximal nail matrix. Okay, that is the reason we have this. These are the nail pits. If I just zoom it in, this is definitely not because he was trying to nail his nail, definitely because of the psoriatic findings. Yes, so now let us just combine all of these findings, right, of the nail, just the nail psoriasis, right? So this is a very famous mnemonic. Yes, we use it's just as nail polish. Yes, nail polish, nail art, and all those matte colors and everything, right? So keeping all that aside, nail polish, ladies and gentlemen. What would be the N for? Tell me, what would be the N for? Let's just take this color. N is for, the last one we did is pitting. Okay, this one, pitting. Okay, pitting. O for what? O for galactosemia? Yes, oil drop. Oil drop, right? Or onycholysis. Alright, how about the next one? It is leukonychia, white nails. How about I? Just they just refer irregular nails or irregular pits. Okay. How about S? S is splinter hemorrhages. Okay. I guess one of my images does have it. If not, I'll add it in the notes. Yes. How about H? Yes. Tell me. What is this? Hyperkeratosis, right? Hyperkeratosis. Okay, fine. So this was all about the nail finding. Yes, the nail polish mnemonic. It is a very general mnemonic we all use, right? So to remember the nail findings in this. So it's been used on for like years and years. So that was all about the nail psoriasis part. Okay, so now let us move on to the next topic, that is going to be Psoriasis Vulgaris. Yes, this is also one of an individual disease. It is not in the classification of the psoriasis, but in the classification of Papulosquamous disorder. We did, right? In the first page we have this name written, Psoriasis Vulgaris. Okay, so do not get confused that is it a type of psoriasis or not. It is not a type of psoriasis, it is an individual disease. Okay, all right, so let us get, it is a very rare finding, yes. And first of all, it is follicular hyperkeratosis. Yes, because of this we have extremely scary lesions right on the hands and feet. Yes, rubra means red, so red orange scaly plaques are seen. Yes, red orange scaly plaques are seen. And the most important thing, yeah, very clinically demarcated thing is that we have islands of normal skin, islands of sparing. If you hear this word islands of sparing in dermatology, is going to be Psoriasis Vulgaris. Okay, definitely we have to we have to correlate with so many things as well, but it is a very good differential. Okay, islands of sparing. Okay, what is the dominance pattern here? It is an autosomal dominant. Okay, it is an autosomal dominant condition, but more this is more common. The sporadic variant is more common, yes, than the autosomal dominant variant. Okay, the next one is the etiology. Yes, we just did the etiology part, that it is sporadic, but why is it happening is because of the immune dysfunction. Yes, and the CARD14 gene mutation. Okay, it could also be because of some bacterial infection or drugs. Moreover, everything is just under idiopathic part. Okay, yes, so yeah, we have a gene mutation and bacterial infection as well. Okay, but the histopathological finding is the most important in all of them. Okay, if we want to take two words from this PRP, it is going to be, the first word is going to be this, and the next one will come in a while. This is alternating bands. Yes, alternating bands of normal and parakeratosis. Okay, all right. Alternating normal and parakeratosis. What does parakeratosis mean? I hope you know. Okay, all right. This is very key finding. Yes, in this one, the histopath findings are very key. Okay, so alternating bands of normal and parakeratosis. Okay, fine. Let us dive into the lesions. Yes, if you see here, yes, right here, this is also very key findings, yet not discussed, but you can see over here, you can see, yes, in the hands, yes, and also here. But over here, the island of sparing is not seen. Island of sparing in the seen in different image. Right here, you see, there is island of sparing. Very clear demarcation. That the whole body is involved, yes, but this is not involved. Okay, alright, so I hope that one word is very clear to you. Okay, so I hope this island of sparing thing is very clear to us. Yes, and let us go on and continue with, we just completed the histopathological findings. Yes, so clinical presentation. Okay, what are we going to see, right, in the patient? So first of all, I'll just straight away expose you to this image right here. What would be the best way you can describe this image to me? Okay, first thing, let us continue with the histopathological finding. All right, so we'll come to that point again. All right, so follicular keratotic papules, yes, we will find on the face, scalp and trunk. Yes, okay, and they would merge with each other. They would merge with each other and they would form reddish orange scaly papules. Okay, yes, scaly plaques, papules will be seen. Okay, you can see in this image. Yes, okay, very clearly we can see this. Now coming on to the next point is the island of sparing. Alright, the island of sparing thing is there. We just discussed about that as well. Okay, where do we see more of it? It is in palms and soles. Yes, thickened yellow keratoma with painful blisters, painful fissures, right? We see Yes, so you see these is very painful condition to have. Okay, all right. And one more thing, yes, we see over here is this image, right? This is what I wanted to show you before. Okay, so alternating things, we just read about the alternating parts, right? So we have some alternating parts of what? Question to you guys. Yes, so as I said you that, okay fine, there are some parakeratosis and the normal skin. Parakeratosis, normal skin. Okay, because of this there are some bands being formed. Okay, you can see here that this is the affected area, normal area, and if this was continued, yes, affected area, normal area, right? Because of that, what are we having here is we are having an alternating band like structure is formed. Okay, all right, that was one thing. We correlate these two things together. Okay, and what are the nail findings do we see is subungual hyperkeratosis. You remember that image? Yes, subungual hyperkeratosis because of the excessive proliferation of the basal layer of the nail. The nail was being pushed up, right? And what was that finding? The name of that finding was onycholysis. Okay, if you remember it very clearly. Splinter hemorrhages are also seen. I'll try to add this image. I forgot to add it here. Okay, splinter hemorrhages. These are the hemorrhages which are seen in the nails. Okay, I'll just try to make one for you guys then. Okay, and right here, if you see, it will be just like this. Yes. Okay, not this one, just like this one. All right, fine. What are these pits? Yes, tell me. Pits, right? Pits we find in this matrix. Yes, the nail matrix. Okay, fine. So we have two findings here, that is subungual keratosis and splinter hemorrhages we have seen. And one of the very key word, right? I told you there are going to be two hot words in this chapter. Yes, so this first was the alternating bands. Yes, the next one is this. Okay, what do you think this is? It is a grater, right? It is a grater for something. Yes, so what that something could be, probably we call it as a nutmeg grater. Greater papules. Okay, so we have this nutmeg grater over here. So one of the thing I would like you to see here is just try to compare both of these two images. Okay, so now you will know and you will remember it very clearly. Okay, both of these two findings, that nutmeg grater, this device and the appearance. Okay, alright, fine. To go on with the next thing is what classification we would use. If you just go ahead, we just need to remember the name, that is Griffith classification. Okay, Griffith's classification we use. It has total 6 types, but we only need to remember the first type, that is the most common type. Okay, alright, age group is in 60 years, 40 to 60 years. Okay, that is the most common finding in them, most common age group to have, that is 40 to 60 years. Okay, treatment again we'll discuss more, but this is just for the PRP part. Emollients, yes, to manage the moisture of the skin, we will use the emollients. Yes, oral retinoids we will use, isotretinoin that we will use that, oral retinoids. Methotrexate to control the lesions, the lesions. Very effective, Cyclosporin, I hope you can remember it now. Earlier 2 times we discussed this already, right? Where was it? It was we were using in 𝗵𝗵𝗵𝗺 if the steroid were not contraindicated. If they were contraindicated, we were using this. And the second one was when in flare-up reactions we were using cyclosporin. Okay, and we also use azathioprine and mycophenolate mofetil. Okay, as long as the name sounds is important. Okay, all right, this one is important. So coming on to the next part, right? This is going to be the signs of psoriasis, not signs and symptoms, signs of psoriasis. Okay, Auspitz Sign and all these signs, right? So we all know, but today we will see why they are forming. Okay, now you will know all the whys and everything behind it. Okay, so let us just start, right? So if there is a lesion, right, if there is a lesion on the skin, we just try to scrape the lesion off. Okay, if you just try to scrape the lesion off, this process is called as grattage method. okay, and in this process all the findings we would see, okay. Nothing much, we just took off the lesion on the skin, okay, and it is like this, scaly, non-scaly. If it is scaly, what do you think the psoriasis is? Okay, what do you think it is? Is it inverse or is it the chronic type? It is the chronic variant, right? Okay, it is not inverse. This much we can say, right? Because it is scaly. Okay, this much we can say. Please mind this. If I zoom it very in, okay, what do we see here, ladies and gentlemen? Some hemorrhages. Okay, but before that, we have to encounter one more term, that is Vulgaris membrane. Okay, this word is very important because the Auspitz sign we see, you know, it is being bombarded so many times that we don't know why it is forming. Okay, Vulgaris membrane is seen after scratching. Simple, nothing much, nothing fancy. It is a very thin membrane. Okay, this membrane, when removed, we see Auspitz sign. Those are the small pinpoint hemorrhages. Okay, pinpoint hemorrhages. Okay, but these are absent in pustular psoriasis, obviously, right? In pustular psoriasis, we had two types. What were the two types? Tell me. Localized and generalized type. Okay, all right. Those two things we have to remember, that the pustular psoriasis has two things: localized and generalized. Okay. Why do we see this? Is because of these blood vessels, right? If you remember, when we were doing the histopathological comparison of the two things, right, in the normal dermis and the affected psoriatic patient, yes, what was actually happening was there were tortuous blood vessels. Yes, so correlation, tortuous blood vessels in the dermal papillae, right? Because of these, when the skin flakes off, yes, when the skin flakes off, we are able to see the splinter hemorrhages. Okay, also called as this Auspitz sign. Pinpoint bleeding you would see. Okay, so now do you know why and how about all these three signs? Yes, very important thing, right? Very important to understand what is Auspitz sign, when it is formed, how is it formed, why is it so. Do you please I would take this opportunity, I'll take you back to that histopathological discussion we did. I just want you to, you know, be clear with this once and for all for your lifetime, that the lesions, the hemorrhages, the pinpoint hemorrhages we see in Auspitz signs are because of these. Okay, because of these capillaries. If this is flicked off, this would definitely bleed, right? Yes, they would definitely bleed. Okay, alright, so I hope that one point is very clear to you. So one thing is done. Alright, so we are done with this. All the findings, all the signs are seen. Okay, now we'll go on to specific phenomena that is seen in psoriasis or other diseases as well, that is Koebner's phenomenon. Okay, very simple but very easily confused. Okay, Koebner's phenomenon. What does it mean? That new lesions develop where? At the point of irritation. Okay, new lesions start developing there. Okay, for example, you can see in this image, yes, so new lesion develop along the lines of trauma. Okay, in this could be true lesions or could be pseudo. Yes, true Koebner, pseudo Koebner. True Koebner, who in which we can see in psoriasis, the topic of discussion, lichen planus and vitiligo. Yes, all right, these three we can see. Okay, and in pseudo Koebner phenomena are seen in warts and molluscum contagiosum. Alright, so pseudo Koebner phenomena. Why I am telling you this is because in molluscum contagiosum, when we will learn about auto inoculations. Okay, that one lesion is because of one lesion we have spread to the other part. Okay, because of one we have it spreads by itself. Okay, fine. So that is molluscum contagiosum. We will also discuss about this in very great detail, right? So if one lesion we have, right, so this lesion we call another lesion. We have this new lesion. Now this lesion will also have another lesion. Okay, all right, fine. So it is a pseudo Koebner phenomena. How about the next one? This is true and pseudo. In true, the examples are very important in Koebner phenomena. Okay, all right. So that was all about the clinical part and everything about psoriasis. Okay, now let us continue with the treatment part. Okay, if you have just gone through the rapid revision part, even there I have discussed a very concise manner of this as well. Okay, the treatment part. Let us start. What is the treatment? First of all, how to approach a patient of psoriasis? Very important, yes. So how to approach a patient of psoriasis? Okay, that is the question. First of all, we definitely have firepower in our hand. We can use methotrexate, we can use cyclosporine, we can use emulsions, we can use immunomodulators, biological agents are there. We have this army of drugs with us, right? But would you give all to all? No, right? We won't give. But what is the agent that would decide that, okay, fine, he should get the most highest power of treatment and he should just get like a normal regular treatment? How would we decide it? The answer is body surface area. Alright, if you see a body surface area less than 10%, topical. Okay, so that is the first one. Okay, if you see any patient who is just involved to 10 to 30% involvement, phototherapy. More than 30% systemic. Okay, so I hope you can now think by yourself. When you see your patient, how would you decide the course of your treatment? Let us continue with individual parts. First of all, we'll see about the topical ones, right? So we have corticosteroids. Yes, topical corticosteroids we have, and we would give vitamin D. Why vitamin D? Yes, because it reduces the proliferation of the keratinocytes. Okay, we would give topical ointments which have vitamin D. Okay, alright, it would decrease the proliferation of the keratinocytes. Very important points. Okay, coming on to the next one, that is phototherapy. Okay, the phototherapy. Do we give phototherapy to all? No. When do we give it? When it is between 10 to 30%. Okay, fine. So there are two regimes that we usually follow. Okay, how does this work is, we give the phototherapy to the patient. It is a very selected spectrum of light we use in this. It will be discussed, but just to get the concept right, I want you to understand how this works. Light, yes, it falls on the lesion. Yes, a specific spectrum of light we use it, a specific wavelength of light we use it, falls on the lesion, right? What it does, it reduces the cytokines. Yes, pro-inflammatory cytokines are reduced. Okay, because of that the lesions are suppressed. Okay, all right. There are two regimens, okay, we follow here is the Gokerman's regimen and we have the Ingram regimen. Okay, alright, so I hope I am pronouncing it right. Yes, so don't scrutinize me for that. Okay, alright, so in this one what do we do is, there are two things. That first of all, we use 𝗲𝗲𝗴𝗵 application on the exposed area. Okay, and then we would expose it to the sunlight. We would to the UV light. Okay, with a very specific wavelength. Fine. So Ingram regimen. Okay, what are we doing is, first we are using cold tar application, then UV light exposure. Yes, and the key point over here is anthelin application. Okay, this is the key point. In anthelin application there is Ingram regime. Okay, how I remember this one is by anthelin is Ingram. Okay, alright, you can also use the A part if you want, depends on you. Okay, this is obsolete. Okay, this regimen is obsolete. Alright, how about the next one? Yes, so we are going into the systemic part. Okay, calcineurin inhibitors. Okay, calcineurin inhibitors, what are these? Tacrolimus. Okay, this is one of it. This is an individual point that I want to discuss with you. Calcineurin inhibitors, when do we use it and why do we use it? Okay, for example, we have extensive coverage of psoriasis on the face. Okay, alright, and if you know that, even we also discussed this point when we discussed about the lesions in the skin, that excessive use of corticosteroids on the face causes thinning of skin. Yes, and it is also in used and also in scars, right, and also in acne, right? If somebody is using corticosteroids, causes skin thickening, also causes predisposition to hyperpigmentation. Yes, so if we don't want to do that, yes, that we know it is a side effect of using steroids on the face or any other skin. Yes, so in that condition we would use tacrolimus. Okay, in that only that condition we would use tacrolimus, because less risk of skin atrophy. Okay, I hope this point is very clear to you. Alright, how about we continue about phototherapy. Okay, I just wanted to include that point very separately. Phototherapy, it increases the anti-inflammatory cytokines. Okay, clear? This one point is clear, we already discussed with you. What are the two spectrum we use is UVA and UVB. Okay, UVA, UVB, these two we use, and in UVA there is specific wavelength we want to use is between 320 to 400 nanometer. Okay, but more beneficial is UVB, that is from 290 to 320 nanometer. Okay, if you ask me one word, like one number, if it is from 311 nanometer, plus minus 2 will be the answer. Okay, fine. The next is PUVA. Okay, and over here we will use psoriasis plus UVA light. Okay, this is what we are going to do. So what happen is, this binds to the DNA, and application of this binds to the DNA, and the UVA destroys the cell. Okay, this is important. Alright, so this point is done. Side effect of PUVA is, for the long term we'll have either skin cancer or cataracts. Okay, for long term usage, and nausea, vomiting is just immediate side effects. Okay, I think these two, nausea and vomiting and giddiness, and I think these are the most abused ones, right, in all of the medicine. Nausea, vomiting. Okay, on to the systemic ones. So it is used if more than 30% of body surface area is involved. Okay, methotrexate is the drug of choice for us. Yes, we already did it before, right? Methotrexate, we use it in a lot of conditions. Yes, so it is a DOC, drug of choice for erythrodermic psoriasis, chronic plaque psoriasis, is it inverse, chronic plaque psoriasis, and psoriatic arthritis. Okay, in these three we use methotrexate. This, the mechanism of action is 𝗲𝗵𝗺 reductase inhibitor of methotrexate. Okay, what are the side effects of this drug? Very potent drug. Yes, what are the side effects? First of all, it is hepatotoxic. Yes, it causes bone marrow suppression, nausea, and teratogenicity. Okay, the side effects, important side effects, we have to remember them. Okay, hepatotoxic is the most important one. Okay, all right, and the next one is acetretin, vitamin E derivative, vitamin A analog, vitamin A derivative, acetretin. This is a sort of magical drug for us, yes, in dermatology. Okay, DOC for pustular psoriasis, yes, okay, pustular psoriasis, acetretin. Okay, we would use. For erythrodermic psoriasis, if we are not using methotrexate, we are supposed to use acetretin. Okay, all right. Vitamin A analog, over here if you see, vitamin A analog could be of two types. Yes, isotretinoin and acetretin. Okay, isotretinoin, wonderful drug for acne and aging. Okay, especially for aging. Yes, the ones who are aging, right, we have these wrinkles and the forehead marks, the crow's feet, and the wrinkles which are there. But if we use isotretinoin very smartly, definitely we can have very good results. Yes, magic drug, isotretinoin. And acetretin, we just said that we would use in pustular psoriasis. Okay, that is the indication for it. Retinoids, this is one other application of PUVA. Yes, psoriasis plus UVA band. Okay, retinoids plus psoriasis. Yes, we apply retinoids and we give the phototherapy. It is very effective in chronic plaque. Okay, all right, it is very effective in chronic plaque. All right, that is one thing. What are the side effects of acetretin? Is dyslipidemia. Okay, increase in blood, either triglycerides, yes, would be increased. Yes, okay, HDL, LDL, or triglycerides, one of the three would be high. Yes, side effects is dyslipidemia. The next drug we would use if there is more than 30% involvement, that is a systemic involvement, is systemic drug would be cyclosporine. Okay, cyclosporine, I told you that it is used for flare-up conditions. Okay, flare-up conditions, if you see, cyclosporine would be the answer. Okay, just to manage the patients immediately. Severe erythrodermic psoriasis, I hope you remember this one, the erythrodermic part, more than 90% involvement. Okay, see, now if you know the meaning of this, right, it is very easy for us, very easy for us just to know that, okay, fine, just by this one word we can understand the meaning. And in impetigo herpetiformis, yes, so if you remember earlier I was explaining you, right, impetigo herpetiformis, is it a misnomer? Yes, What is the DOC? Steroids. Do we use steroids in psoriasis? Systemic steroids? No. So why are we using it? Because it is a contraindication, right? Yes, this is an 𝗵𝗵𝗵𝗺 we will be using the steroids. But if steroids are not, we cannot use it. If it is a contraindication, what would we do it? Yes, we would use cyclosporine. I hope you got all that interconnecting link. Yes, systemic steroids are the DOC for 𝗵𝗵𝗵𝗺. Yes, and also these are the drug of choice for psoriatic erythroderma in pregnancy. Okay, in pregnancy, if there is psoriatic erythroderma, we have we would use systemic steroids. Okay, now coming on to the biological agents. Yes, so I told you before, right, we will discuss about this. Yes, the biological agents which are there, and this is the last topic of the whole psoriasis topic. Okay, biological agents. So first of all, I would just wanna get your attention to this one drug, apremilast. Yes, which is a PDE4 inhibitor. Okay, so I don't remember any drug, but I remember this one very clearly. Not because of this is important in the exam, because after one day, like me and my father, we were just having a tea, like in evening tea, we were having it. Okay, and then a father goes like, yeah, do you know in psoriasis we use these immunomodulators, you know? So yeah, I know we use methotrexate in this and the steroid in this, and I was very confident, okay, about what I was asking. And he told me like, do you know any biological agents? I was like, no, you know, infliximab, tocilizumab. I told him like, I know these two threes. Okay, he said, okay, fine, your answer is correct, but do you know any PDE4 inhibitor? He said like, no. I was like, no, this is not in my syllabus. Okay, that is why I told him that this is not in my syllabus. Okay, it is not in my book. And he was like, okay, fine, open your book and see. Okay, and I opened my book, my notes, and over there I saw apremilast. Okay, that was the answer he wanted me to tell. Okay, this one drug, he wanted me to tell the answer of this. Like what I told him, like, this PDE4 is not included in my book. I was shocked that I had this in my book. Yes, and I didn't read it properly. My head was so much focused on methotrexate and the corticosteroids, and that I just overlooked all the biological agents. Okay, because this is in the last part, our mind gets fatigued. Yes, and we don't focus on these things, right? So please bear with me, don't do the same mistake I did. Okay, and probably maybe your father or your examiner, right, could ask questions from this topic. Now when I have your attention, I will continue with the topic, biological agents. So CAMP, yeah, so CAMP has been converted to CAMP is converted into AMP, cyclic AMP is converted into AMP by PDE4, right? Okay, and this is being blocked by apremilast. Okay, this drug blocks it, and because of the blockage of this, there is increase in CAMP. This is an anti-inflammatory intermediate. Okay, this has anti-inflammatory cytokines. Okay, because of this, there will be complete suppression of the lesions. Yes, because of this. Yes, because we can control the inflammatory cytokines. Please go and do you remember the first 10-15 minutes we discussed about the psoriasis? Do you remember when I told you about all the positive factors? What did I tell you? Yeah, we discussed about, I told you like, please get your attention on the word inflammatory. Yes, so now we are treating the whole condition, right, by targeting this, which causes increase in this and gives us a very desired action. Okay, all right, that's one drug. I hope we can if we remember some story or something, you know, we will remember the drug. Yes, we will remember the drug, anti-inflammatory cytokines. Okay, and the next one is psoriatic arthritis and plaque psoriasis. We would use PDE4 inhibitor. Okay, apremilast. Okay, apremilast. All right, fine. How about the next ones? TNF alpha inhibitor. Yes, adalimumab, etanercept, and infliximab. These three are there. Yes, very potent, very powerful drugs. Yes, infliximab, monoclonal antibody. T-cell inhibitors are tocilizumab. Okay, all right. That is for the biological agents. So I hope this part 1 of papulosquamous disorder was very useful to you, and thank you for giving me your time, and I hope you can just go over to all of this whatever we discussed, right, in it. And if there is any doubt or anything, you can definitely refer to these notes. You can search in the notes, right. We have created it in a very good manner. Okay, all right. So that is it. For the next part of the papulosquamous disorder, we would be discussing, the first topic would be lichen planus. Okay, all right. Thank you so much for listening.